Zone 3 Podcast. I am Robert.
Yes, and I am Reggie.
This episode is brought to you by Aegis. Thank you, Aegis.
Yes, thank
today
you.
we are joined by...
Thank you so much, Aegis, for doing this and sponsoring this.
Yeah. And today we are joined by Kristan Harrington.
Yes.
Thank you, Kristan, for joining us.
Oh, thank you, Robert. Thank you, Reggie. We, Bill and I always like coming out here and seeing you guys and doing these podcasts with you. So thank you so much for doing this for
The feeling is
everyone.
mutual.
Right?
Yeah.
It's the heat of the summer, too. Like, we were in the meat of it right now.
Well,
Actually,
you know
no.
what? And you guys had rain.
Yeah.
I know,
which
it's kind of strange.
I've been to Arizona twice when there was rain, and people go outside to see the rain.
Yeah. Oh, yeah.
It's like it's
I would
snowing.
jog.
It's like it's snowing.
It was like they're like,
Some people take shelter. They don't know what to do.
right. And so
They close the schools.
I found that to be so interesting when I first was here a few years ago and it rained. And then y'all had flooding because you have no system of like draining the water. Well, in Atlanta, which is where I'm, shout out to the Hotlanta, that's where I'm from. Right. We had thunderstorms 2 or 3 times a day.
Oh, wow.
And so we lose power all the time. We have a generator. I mean, things like that because of the storm and all
Kudos
that.
to you for catching on it because that's very insightful. A lot of people don't realize that the reason why we have so much flooding issues is because we're not equipped to deal with so much water. There's not the drainage that the west or the east has.
So you're saying I'm insightful?
Yeah.
That's why we got you here today,
Wow.
right?
Now I already feel good.
There's a long list of adjectives for Kristan.
Okay. We'll move on from there.
But one of those adjectives would be like breast imaging expert. I would say that you have a extensive knowledge on that, and that's actually what today's topic is on.
Nice.
Breast imaging, specifically MRI. So if you would, maybe just kind of dive into that. We sort of have an outline, but feel free to take it anywhere you like, Kristan.
Perfect. I will first of all say that I did start doing breast imaging research when I was a student as well as a technologist at Emory back in the day when there was literally not your common. It was all research facilities that were doing breast imaging. And from that point to this point, it's come so far. But that being said, in alignment with that, the number of cases of breast cancer have gone down as far as the number that are diagnosed. So
What would you contribute that to? Like just false positives? Or?
I would contribute that to a number of things. It depends on if you're going down the MRI, if you're going down that road or that lane, or if you're going down another. One is a huge reason is not using hormone replacement therapy, HRT. That has had a huge link as far as not using that now has had a huge impact on the number of cases. So I do have some statistics. So I will be kind of reading through this for everyone to kind of see. This is at the end of every year, breastcancer.org. It's a great place to go to find out information. This is where I get the information from the prior year. So there were over 266,000 new cases of invasive breast cancer. And I'll talk a little bit about different types of cancers a little bit later on. There were 63,000, close to 64,000 non-invasive. People do not realize that men get breast cancer.
I've done an breast MR on a male patient before.
So that is something I'm going to let you speak to in a few minutes. I would love to hear about that because I've never done one on a male. I have not. Right. And I've never done a mammogram on a male. I've never done any of that. But my dad's best friend had breast cancer and he was a male. So it's out there, but people don't realize. Obviously, the reason why it doesn't get a lot of recognition is because look at the number of cases. It's, 2,500 just over. But it's also important to note that 85% don't have any family history. And that's literally, again, these are just the stats that are out there. But if you'll go to the next one, it actually shows you, great job. Yeah. It shows you that in 20, I'm here for you. In 2020, the number of breast cancers over the past 25 years has dropped 40%. That is over 300,000 lives saved. And I will tell you, there are a lot of components and elements to actually attribute this to, but I have to really, it's my love, it's my passion, MRI, obviously, but I'd say that it has a lot to do with that, and having more accessibility to having the MRIs done, and then how far MRs come to kind of meet that together. And I really think it has a big part as far as being the modality of choice.
Right.
Again. So anyway, I think it's important to go through, and I want to talk about risk. So we have a slide to go to. The statistics are there. Those are, the deaths per year. But let's just look at, we have established risk. And the reason I want to go through different risk is because we have emerging risk. And this is something that's the first time I've ever seen at this website. And I find it fascinating. So, obviously, a risk would be being a woman, American women, invasive breast cancer. BC is always going to mean breast cancer. When you see that on my slides for this, it said, okay, well, we had 266,000, a little over new cases. American women. And this is just copy and paste from there. Non-invasive is 63,000. The reason non-invasive is not as many cases is because it's not as symptomatic. I mean, think about that. You don't have your nipples not pointing inward. You don't have these different things that are happening. The skin changes around the breast. And once you do, it's typically more invasive. And I'll talk a little bit about invasive versus non-invasive in just a minute. As far as white women have a slightly higher risk as compared to black women, but when black women are diagnosed, it's typically more aggressive. The reason behind all of this, I'm not exactly sure. It's genetics. They're studying all of the.
Right.
I have no idea. Then Hispanic and Asian. So white women by far are slightly higher risk. The age 55 years or older, approximately 2 out of 3 are invasive that are diagnosed for breast cancer. And if you have dense breasts, you are twice as likely. Now, this is very interesting. Once we get to the end, I want to talk a little bit about a good bit about, if we can, abbreviated breast protocols that are being done and almost standardized now. So if you have dense breast and that's all that you have, you're more than likely.
Dense. What do you mean by dense? Per se, like the.
Okay, so I have to be very careful in how I answer this one.
Oh, man.
Are they adipose tissue mostly?
Oh, I see. Okay.
Are they
fat? Okay.
Or is it more actually tissue? Yes.
I see mammal.
Yeah.
Okay.
Yes, and then they do.
You understand though?
Did you understood, right?
Oh, I understand, Kristan.
Okay. Well, I'm going to take a sip of my Coca-Cola.
All right, let me ask you this, though, because I do have a question. I've never thought about this before. Do you think that there's like some sort of like common denominator based on breast size? Because you said the more dense it is, but what about just cup size? Are you more susceptible if you're, say, a D versus an A?
The density change?
Statistically, you have more breast tissue. Does that mean statistically you're more susceptible? Is that a stupid?
There is no stupid question.
Thank you.
I think we've all established that. But I
told you it wasn't a stupid question.
I also have a ... in how I end that statement, but I'm not going to say it here. So we'll leave it there. All right. Yeah, try to be as PC as possible, but there are no stupid questions. ... I actually have seen. I try to point to the data, not to anecdotal information.
No,
but you bring up a
that.
good point. But I've not seen any papers, and I actually do read. I do try and stay on top of all of this, and I have not seen anything. But the more there is there. I would say,
right?
I would say the higher the possibility. But then when we talk about some of these, it's not an established risk, okay?
Okay.
It's not.
Okay.
When you see the emerging risk, it would say big boob versus small boob, right?
Right. It would.
Because based upon how crazy these things that you're about to see.
Okay.
Okay, so you see this. Dense breast is more than twice as likely to happen. So just going on to the next one on established risk. So family history, first degree relative, you have double the risk. Genetics, 5 to 10% pass from parent to child. A personal history of a previous breast cancer, that's going to be something you have to think about. Now, this is something that was even before my time, and I'm right at the door of 50. They used to do radiation to the face and the neck around the age of before the age of 30, and that was to treat non-Hodgkin lymphoma, and it was also for acne treatment.
Oh.
Not even joking. This is scientific.
I could use that in high school.
Then you'd be at higher risk for male breast cancer.
All right, take it back.
You got saved. Take it back. Yeah. No, I never knew this. I literally, it was for acne treatment. Wow. So you'll see there it says no longer used.
Right.
Yeah, I kind of get that, don't you? Pregnancy, if you've had a pregnancy before the age of 30, you're less likely than someone like me that had children when she was old. Breastfeeding, your menstrual history, how early. The earlier you start having a menstrual cycle, the more likely you are to have breast cancer.
Oh, wow.
Yeah. And so, and then HRT, the hormone replacement therapy, I would say is probably the biggest impact. And I will tell you, I talked to different medical markets around the U.S., and some places still do use as a regular practice the HRT. Oh. So it's something that needs to I really hope people are listening to that, because that's a huge one.
Right.
Now, what's really interesting is what I found on breastcancer.org is the emerging risk. And that would be on the next slide that I want to show everybody. If you have low vitamin D levels, so it may play a role in controlling the normal breast cell growth. Right, vitamin D. So I guess but if you notice, it doesn't matter who in my family goes to the doctor, they always say we have low vitamin D, and we're in the sun all the time. Right. It's not like we live in, a place that doesn't have, the sun out, and we are out there, football games, horseback, we're out there all the time. We all take vitamin D.
Interesting.
Yes. No, it gets better, Reggie. Light exposure at night. Factory workers, doctors, and nurses. So this is the slide that Robert should be really looking at, because this is where it would say a larger breast versus a smaller breast. Because, okay, so if you have light exposure at night, okay, even if there are too many street lights where you live, wow. This is emerging risks that are being studied. Wow. And again, I didn't just wake up and make this stuff up. Make up.
Is that like a lack of sleep or something? Or what do they mean by light exposure at night?
Maybe everyone needs to get those blackout shades. Maybe it's if you live in the city and the street lights, because you see the street lights actually that are on that picture. It just says even if there are too many street lights where you live. So, think about these things. Makeup.
Try to be professional.
Makeup. That's why I don't wear any makeup, because... No, I'm just joking. I'm sure I look like a clown, but that's fine.
You look like a cover girl, Kristan.
Yeah.
And your hair looks great, by the way.
Oh, really?
Yeah.
There's a debate around curly versus straight, but,
I like... Well, you were curly last...
Yeah, I was curly.
Yeah. I like it straight, too.
Well, my family votes for straight.
Oh, okay.
But there's other people that like it curly.
Do you find that the humidity here or lack of affects your hairstyle?
I love going to Vegas. Just let me say that, because I get excited a number of things, but the biggest thing is my hair's going to look great all week. That is such a chick thing, isn't it?
Well, Reggie does it too.
Yeah, me too. I'm vibrant too.
Is that why you live here? Because typically,
oh yeah, my curls, woo.
Looking good. So, but you can't wear makeup anymore, Reggie, okay? Because the cosmetics, chemicals in food, I don't think that there's anything possible as far as there's going to be pretty much chemicals in everything. I certainly, with a big family, can't afford having, all of our food to be completely organic. And then is it true twice removed, not organic at all? Lawn chemicals, chemicals in sunscreen. This is just totally just an aside, FYI. Do you know I researched this? I have not worn sunscreen, and I've been to the Caribbean. I've been all over for at least 8 years. We do not own sunscreen in my family.
Likewise.
We don't. Do you know that not breast cancer, skin cancer has over doubled over the past 25 years? And think about, it's probably over 30 years because I researched it about 5 or 6 years ago. It's more than doubled, but think about the SPF. It's just gone up and up, which actually also affects our vitamin D level. I know this is a total aside. I'm just adding this in as information. Yeah. We don't use sunscreen. And I was out in the sun all weekend. Do I look like I got sunburned at all? No, I don't. Your melanin just automatically starts to go up. You get more used to it. And again, nobody in my family wears it. I will say, we're all going through COVID. Yeah. I just want to say this. As far as the vaccination goes, there has been some data that it does increase the lymph nodes. And that's always something we're looking at is increased size of the lymph nodes when we're looking at invasive types of breast cancer. Right. So with the COVID vaccination, there was also that concern. And my business partner, pretty sure everyone probably knows, is Bill Faulkner. Oh, yeah. He and I were actually doing another podcast. Yeah, I think somebody has. Yes, I think somebody has heard of him before. If not, I'm going to do the big plug for Bill Faulkner. He's a great, smart guy. But we were talking to someone else, and it also, it's been known to do the same thing with just like a basic flu, type of shot. I don't have the data right here in front of me, but that's kind of how that was, addressed. Oh no, you get the vaccination, then don't go have your lymph nodes checked out for your breast.
Oh, so she just spaced it out there pretty much.
I don't know. I don't have the data on how long you space it out.
Right.
Well, there is a correlation, it sounds like.
Yeah, but there's also a possible correlation with like I said, just getting normal types of vaccines like we get every year. I have to get the flu shot. Right. Working PRN at the Children's Hospital, I have to get it by November 1st. Right. I have to give them proof that I got it. They'll give it to me for free if I'm there. I just don't work very many days a year. Right. So, it's known to be like that as well. I mean, the same type of situation. I don't know if it's a bigger effect with the COVID vaccine. I don't know that answer, but I'm just saying that is something that people should kind of be aware of.
Right.
So with a quick Google search, and by the way, this is total confirmation bias, but 2 previous studies suggest a correlation between breast size and cancer risk. The authors noticed in one published in the International Journal of Cancer, Harvard researchers found that lean women with a bra cup size of D or larger had nearly twice the risk of cancer as lean women with a bra cup size of A or smaller.
All right.
Now I could also find information that probably says contradictory.
I'm safe is what we're saying.
Yeah, exactly.
I'm safe. So anyway, I wanted to address that. And you know what? Thank you so much for clarifying that. And coming from Harvard.
I don't know what that means. Because in this very same Google search, I see that it says, when it comes to developing breast cancer, size does not matter. So it's confirmation bias.
Confirmation bias. So basically, you just contradicted everything you just said by
but I'm too damn honest to admit otherwise. But I'm saying I could find information that confirms that. I could find information that confirms it doesn't.
Right. And probably pretty much we could do that for every single argument out there for anything that's ever existed, quite honestly. Absolutely, yeah. So does it matter? We're not sure. Because if they're saying streetlights are a higher risk, I mean, to me, that's like, I've not seen the scientific data. Obviously they have, because to me, there's several very trusted websites that I go to for the information. Right. I just found this whole sheet of emerging risk. And obviously, I think chemicals, all that can be something that's understood. But as far as your light exposure, nurses, doctors, factory workers, people just at night, I don't know.
But you're exposed to the same lights during the day.
But you wonder if the sun. Let's talk about this. What if the sun kind of?
But what if you're in the basement of a building? Does it matter what the sun's doing?
It doesn't know.
Right.
All right. You know what? We're going to leave this topic. We got lots to cover.
Leave a comment. And if you know anything, please leave a comment down below. Yeah. For sure.
And I don't mean to challenge you. I'm just processing this as you're talking.
No. I think it's because it's very interesting. Yes.
Very interesting.
People are gonna be like, where did she get that information? I got it right from very, very valid sites that I trust.
Right.
And where I would go, if unfortunately someone in my family, that's where I would go for information, is to these types of websites. And to find for the first time at the beginning of 2021, that these were the emerging risk. I've not seen it may have been there before, but I'm just now seeing these types of things listed. Yeah. So I would assume light exposure at night, if it doesn't recognize night or day, then yeah, and you're in the basement, then I would think that you're exactly accurate. So what about, white nights in Alaska? Do people in Alaska get less breast cancer because...
It's a fun topic. It's
all emerging.
Topic,
you know what I'm saying?
It's an interesting topic to think about for sure.
Alaska came to mind because don't they have times when there's only it's very little time when there's darkness,
depends
right?
On the year. Or it depends on the time of year. If it's winter, it's only a couple hours of daylight. Summer is vice versa.
I don't know. I was there in October.
So you probably right
Me and my
around
husband
the
and Bill and his wife, we all went out there.
Where was my invite?
I sent it. You didn't respond.
I'm bad at that.
I know. But Reggie was told to lie to you because he did respond and we had a great time.
You guys went. You said you just went with a shout.
Sorry, bro.
That was a couple's retreat.
Yeah, we brought him with us. He's pretty special.
Yeah.
So I think it's important. When I started doing breast imaging, I had no clue, anything about breast tissue or what what was going on. I didn't really even know that much about different types of breast cancer.
Right.
I do have to say this, though. I was a poor student when I went to school at Emory, and I went to mammography and told them that they were my favorite modality. I went to X-ray and said, it's my favorite modality. I can't imagine. Then I went to MR, and I was already their patient care tech aide, and I said, MR is my favorite modality. I can't imagine. And MR offered me a job the day before mammo did, and I accepted it.
Oh, nice.
I was so poor, I probably would have done anything just to get a job. But they were all my favorite modality.
Yeah.
They were every single one of them. I think it's important to understand that if you have DCIS, which is ductal carcinoma in situ, what that means is that you've got the abnormal cells are actually contained within the milk ducts. So contained means, I like that word because, it's in an area, it's contained. I can go get that area and it's not gone outside. Oh. So then once you get to the invasive ductal carcinoma, it's now gone into the surrounding tissues. And then the most severe is going to be when you have metastatic. And unfortunately, again, because I was talking about in the very beginning of the podcast, it's really important to understand that it's very asymptomatic. And I really want to urge people to take it so seriously. If you do have swelling, if do self-checks. I am not an MD, but we as women and men, we should be seeing, there's a little lump there. Get it checked out. There's no reason not to, because the earlier you catch it, obviously, right, the much higher the survival rate's going to be. The path of treatment's going to be totally different. The impact on your family, it goes on and on. So again, you saw the numbers. It is much more likely to be
how does the process start? So do you just go straight to getting you feel something like, I need to get a breast MR, or do people they normally get a mammo first?
Okay, so there's debate around this, quite honestly. Do you want to start? There's a baseline at 35. You got a first degree relative, like your mother or something has it. This is a discussion you have with your doctor. So you go to your doctor, you get your annual exam, and they say, okay, well, you got on here that your mother died of breast cancer. You have these different check off points. Okay. You might want to go ahead and have your baseline done at 35. Now, this is information I got many years ago because I don't have a first degree relative that's ever had breast cancer, thank goodness. But then after 40, then they said everyone needs a baseline at 40. Well, then we started having all this information about, over ionizing, radiating people. So we want to do dose reduction as much as possible. So then do you get it at 40 if you have absolutely no indicators? Right. You don't have dense breast. I mean, I'm just going back to your whole, you don't have large breast. I mean, what's all the qualifying, what are those factors? Do you have it at 40 or do you wait till later? Right. And so typically you would start with a mammogram, and I'm not going to give you an age because again, that's going to be so variable based upon someone's history. Then while you're there, so when I was rotating through mammo, which was my favorite modality, just so you know at the time, while I was there, if we did a mammography on someone, we did a mammogram, and they thought that anything was suspicious. At Emory, they immediately did an ultrasound. I don't know if that's common practice, but that was the way that it went. Then if we were doing research, sometimes they would come to Emory.
But ultrasound of the lymph nodes or of the actual breast?
The breast and the surrounding tissues. Oh, absolutely. Okay. And so they would do that. They would, it's very sensitive, these whole issues with women, as far as having their mammogram done. There's a lot of nerves around it. So they would actually watch a video. I think part of this podcast is also about just the patient care. So we would do they would watch a little VCR video. Then we'd do their mammogram. And then, the doctors would always do like a wet read, so to speak, right? Back in the day, they would just look at them really quick. And then they would say, then there was a whole nother conversation. And as a student, I wasn't really involved in that, but I know it's, we just want to see some additional information, which then spikes out their stress. I will tell you, there's a hospital in New Jersey. When I did applications, and I know this sounds so like over the top, but they actually gave all the women that were coming in for to go to the cancer center for breast cancer, they gave them all a rose every single time they came. I just thought that just kind of makes your heart smile a little bit, nice. And a lot of people are like, ugh, that's just obnoxious. No, it's actually a nice thing to do. Right.
What a gesture, right?
For anything, give me a flower, I'm happy.
Right.
So.
I'll take one.
Absolutely.
I gotta wait for 2 hours for the test.
Right. Well, that's another thing, right? I mean, that's a whole nother business talk.
For another podcast,
anything going on. So I think it's important to understand the emotional side. I'm a little bit more. I take things in stride, so it's just I probably don't need the rose or, I just do it. It's basically how I am. I don't need to see the video. Right. Just go in there, squish them to the size of a pancake, tell me if I need something additional. And then somewhere you have to weave in, I'm not going to say the long word because I can't, tomosynthesis. I think I just said it correctly for the first time ever. Nice. But everyone now calls it 3D mammograms, 3D. Oh, okay. And there was a lot of merit, still is a lot of merit to doing that. But MR has even gone above that as far as sensitivity, specificity. Right. So definitely, if you're going to have breast cancer, we want it to be contained within those milk ducts. We want that. And then you want to catch invasive as quickly as possible before it does metastasize, brain, lung. It goes to so many different areas of the body. Right. It is extremely aggressive, and your treatment plan is going to change. I think that I have a slide that talks about Birads. And this is also something that I never truly understood. They also have this for prostate cancer and probably other areas that I'm just not aware of. So it's recognized by the ACR. And it's just a standardized classification. It's not just used for MR. It's used for mammo. I'm sure 3D mammo should be included in there now. Ultrasound. It's used and MRI. But it basically categorizes everything. 0 means it's going to get worse as you go up in numbers. So 0 is, they really couldn't get any information. They need additional, imaging evaluation. Basically, the patient panicked, they moved, they left, they didn't show for their appointment. They're at a 0. 1's just negative, normal. Mammo, just go home. You don't have to do anything else. Go home, be thankful. Then you've got benign findings. Okay, so I'm brought in and I hear, I've got benign findings. That's going to leave me a little bit scared, right?
Right.
Okay, so then we go to number 3. Probably, now I'm getting really nervous. Probably benign findings. Initial short-term follow-up is suggested, whether that's 3 months, 6 months, I don't know. It probably is, how probable is it that it actually is benign? But let me just tell you, based upon imaging techniques that are used in MRI and the different abilities that we have in front of us, what field strength literally can change your Birads from a 2 to a 3.
Oh.
Really?
Absolutely. Absolutely. And one of the talks that I do, just based upon field strength, going from a 1.5 to a 3 Tesla, it classified it because there's pointed borders. It's like spiculation is kind of the way that they refer to it. Mm-hmm. And the smooth borders, obviously, we're going to think, okay, that's going to be more cystic. It's going to be fluid filled. But these things with these edges and these different borders, that's what's going on here. Right. Literally, it was changed. And so that means they needed a follow-up. It went from Birads 2 to Birads 3.
Man.
And that was only changing. And a lot of the information I'll refer back to are papers that are written by Dr. Kristan Harrington. She's out of Europe, and she is by far, to me, the world leader.
Leading the way. Nice.
She's always led the way in breast imaging. She's just has been all over the world. She's a speaker. She's such a knowledge sharer. She's on YouTube everywhere. I think anyone could go search her up. It's KUHL is how you pronounce it. And she's the reason we're doing abbreviated breast imaging, in my opinion. She is the sole reason. She is one of the sole reasons that we are have so many advancements in MRI as far as protocols. So I just want to say that. But I didn't understand. I would see this information, Birads this, Birads that, whatever the number. And I really honestly didn't know it. And I think sometimes we don't know this information when we see it in the notes, but it does make a difference to see that. Then obviously as you go from 4 to 5 to 6, it just gets, it's, need a biopsy or, treatment. It gets worse as you go up, but it is a standard that I think everyone should have some exposure to.
So we should be doing breast at 3T. That should be the standard.
And then we should always be doing it at the same field strength.
When they
for consistency.
Oh, yeah.
I believe, okay, and there's something I'll say with abbreviated as far as consistency. And I believe, this is my opinion, because of the papers that I have read, that I would transition over. I would keep the protocol as much the same until I start talking about abbreviated later on. I would increase the field strength. I understand consistency, right, but there's not going to be consistency because they're either going to get more, they're going to go away post chemo. When do you do the MR post chemo? When's their menses? There's never going to be. So I understand. Okay, to your point, Robert, let's always keep them on 1.5. Now, I'm not saying that a facility that only has a 1.5 Tesla scanner shouldn't be doing breast imaging. I mean, right, there's so many other capabilities that we have to optimize. And yes, that would be up to the radiologist's discretion on, are we going to switch this over? Because, we all know the benefits as far as flexibility. I'm sorry. Go ahead. Let's keep it down. Sorry. Does it keep sinking on me? Yeah. Is it because I'm breathing too heavy on it? Is pushing it down?
That's because we need to upgrade our mics. That's really what it is.
No. It works perfectly. I just thought that was kind of funny. So anyway, I kind of lost where we were at. Field strength. That's really going to be site specific. I mean, I would always prefer, aren't we lucky that we know MRI? Because I think it's when I call about, let's say my husband, I say, okay, well, what field strength are you doing them on? Okay, do you have a transmit receive knee coil? Do you have this? How many channels is it? And they're like, who are you?
I hate taking those phone calls.
Yes.
There is one topic that happens at our children's hospital, and they'll come in and they'll say, I am so glad that you are here today. And they just hand the topic over to me. And I'm like, it doesn't bother me. But they're like, one of them, they're just like, I couldn't answer that question. I'm like, I'm glad I'm here. I'll just go tell them probably what you already knew, but you're just afraid that you're wrong, I'm sure they're probably right. But I will say that I started an MRI in around 94, I want to say. And again, that was the patient care tech aid, i.e. I clean up the vomit, I screen the patient, I put them on change the table out. And so that's what I did for a year. And but then when I started actually scanning, we did a lot of research in cardiac. We were a big cardiac facility, abdominal work, but also with breast. And so But we also have to go back and realize that in 1986, one paper, that's when they actually said, okay, breast imaging is possible. That's all they said, 1986. It's possible. And then there's another paper that comes out so many years later. It was 1991. This is just one paper that I'm referring to in my brain. But it was 1991. They said, yeah, breasts, they did a comparison. And they said it's pretty much 50-50, as far as what we're able to see as far as sensitivity, specificity, these things that we really want to have, a high number. We would like to see a big difference. And they said, the conclusion, which I pretty much know by heart, is, while MRI has its merits, it is because of the high cost of the exam and mammography supplemented with ultrasound is the method of choice.
Actually, wrote that down as a question to ask you later. So I was wondering if MRI is the superior modality, why is it that ultrasound is the go-to or mammo? But you explained that, so I've always wondered that.
Yeah, that's nice.
Well, that's typically the normal evolution, is that you kind of go through that. I'm not sure if someone starts somewhere else. I think that it just I think that's how the...
in the big picture, though, what a waste of money to do the ultrasound, do the mammo, when you could have just done the MRI in the first place.
Right.
But
we're getting
my
there
opinion,
one day.
I'll keep it out.
I feel like one day a lot of things are going straight MR. A lot of things.
And it's confirmation bias, right? But if you're talking about a superior modality, and you
I like that phrase.
mammo,
I'm going to start using it. Confirmation bias.
I just Googled it. What I do is I Google big words. I use them often. It makes me sound smarter.
I'm going to throw some big words in, but I'm going to have
susceptibility. Use that often. It makes you sound smart. Susceptibility, indicative. These
are as big as your words get.
Well, there's bigger ones.
Can you spell them?
Cholecystectomy?
Can you?
You're not lying.
I got more.
Use these words.
Hold on. What is it? Tell me what ERCP stands for.
Oh gosh.
Endoscopic retrospective pancreatic coleos something. Cholangiogram, where they shove the tube down your throat and it's awful. It's like a hose.
And that's another thing, Kristan. All you have to do is say acronyms, and you also sound really smart. So you don't even have to just say ERCP or that DIY or I don't know, make up something.
The DIY that we're going to discuss in a minute. Did that sound good?
I like it.
I like it too. Yeah, I like it too. It sounds good.
Like Birads.
Birads. Well, what do you want me to do from Atlanta? Come in and say Birads?
He's from Georgia too, right?
No.
Yeah, you know that.
Savannah.
You're from
Savannah.
You
Georgia.
cannot tell.
Yeah.
You can't tell really with me either.
Right.
Yeah, many years ago, someone said you cannot be a public speaker with that accent. It really hurt quite honestly, it really hurt my feelings because I'm really proud of my roots. I'm proud of my Southern roots.
He's been going through speech therapy actually to get rid of it. He's very ashamed.
Yeah. Weekly.
You're not invited. No more Alaska for you.
We'll go over things like A, E, I.
Joe.
Oh, look at me. Say it. A, E.
Right. And
You're
so,
sensitive about this.
I didn't mean to call you out.
but no, most people, they say they think I'm from Texas. I don't know. I mean, they do, but they don't peg me with Georgia anymore in the deep southern.
Yeah, there's Southern Belle charm, I would say, for sure.
I've got charm.
Yeah. Texas is Southern. Georgia
It
is
is.
Southern. Either one.
Okay. You find them as similar.
Yeah.
That's disturbing.
Is it?
They're not similar.
See, I'm not
at
part
all.
of that.
So I'm just gonna give up on the whole
You
thing.
can't beat them.
All right, let's just go into the advancements. Obviously, there's different types of coils. Linear coils were what we had to use, and so they were a big circle. We got the breast inside there. We had to do one breast at a time, and obviously, because of the way that coil design is, if they were a D cup or whatever you said, they had a lot of breast tissue. You're going to lose signal as you get further and further away from that, correct?
All right.
And so we just didn't have the capabilities. We also did not have good fat saturation techniques, reliable fat saturation techniques. The fields were not as homogeneous. That's just a fact. I mean,
Right.
you are never going to have a truly...
Implants, right? Add to that implants.
Right. Once again, we did a lot of implants looking for that linguini effect with, the implant actually folding. It looks like spaghetti.
Right.
And so we did a lot. But we were doing this with research files. And actually, famous people can't say it here, but you'd be amazed.
Wow.
Yeah, you'd be amazed.
Dang.
Yeah.
Give us initial.
I'll say this about one.
GW.
This one, there's no way I'll get. I can't get in trouble, and if I can, then we'll
Cut it.
Cut it.
Yeah.
I'm not gonna say the name. I would never
I know
say
it's
the
a
name.
he.
What?
I've narrowed it down to a he.
No.
Keep going.
Okay. This person is famous for doing
Medea.
is famous for doing workout videos. So I go to get this person and I said, I love your workout videos. And then I immediately stopped myself, and I was not fat back then. I said, but I don't do them. I don't do them. I didn't want her to think that I was a product of what her video stood for, which was being in shape.
Yeah, just went into the oldies.
And I was like,
These sort of things.
okay, so you guys can guess later, but I mean, I just wanted to make sure she didn't feel bad and go home and revamp all of her videos that night because of me.
Start over.
I've got to do something. Yeah, so parallel imaging, and when you talk about there's Asset Arc, Sense, MSense, there's iPad, there's all these different types of ways of collecting data faster.
Right.
And then you've got the new different types of sequences that we use.
Right.
All of these things have really helped us. We want as many channels as possible, so that helps us with our signal. We're going to decrease the amount of noise that's collected.
Right.
That is a huge thing. Having that increased field strength. And then with the parallel imaging, we need to be able, I always call it the money scan, is the dynamic contrast enhanced.
Right.
And so to be able to detect breast cancer, it's around, peak enhancement is around 90 seconds. You want to be rapid firing these dynamic, sequences back to back to back. And when I first was working with Christiana Kuhl's protocol, when I started working for a corporation doing applications, I could only get it to a minute and 2 seconds based upon the capabilities of the system that I was on. 3T was not yet released. That's irrelevant really to the protocol I was trying to achieve, but I could only get it to a minute. And now you're talking a matter of seconds. We're just collecting the data, but maximum enhancement of a negative, a type of mass or tumor is going to be around 90 seconds. And so peak enhancement. So that's interesting. And that's important to have these types of techniques. And then again, with the fat saturation, there's something called, these are big words for you, SPARE, spectral adiabatic inversion recovery. Can you
acronym? I like it. I'm just going to say SPARE.
Right. Adiabatic is just strong. It's a strong pulse. I don't know why they
That's
just.
how they describe me.
I don't know why they don't call it stare, but it's a big pulse. No, stare. Never mind. Ignore that one. And so anyway, we have these other techniques. I will say this: if you're using a SPARE technique, then you may have a change in your temporal or your time. It may increase it slightly. It does a range of frequencies, so it's going to be more robust. But also just the uniformity of the systems. Now we want to use traditional FATSAT as much as possible. I'm going to say this to everybody in the United States of America. I hope you are listening. I hope you're watching. If FATSAT fails on a pre-sequence, do not do the dynamic with FATSAT because it's going to fail again. Then you can't subtract it. So then every time I do a breast talk, they say, our patients move. And I say, this is not an issue in Europe. Literally, they look at the pre-FATSAT, and if they see any type of issue as far as they turn it off, and then they subtract it. So why are we moving and they are not? My patients don't move.
Right.
Right.
I've seen that position that, the patient has to be in for a breast exam. And in my head, I'm like, how are they not moving? Because that does not look comfortable.
I say the two most uncomfortable exams for an MRI, and this is only based on what I've heard from patients, breast and elbow. But elbow, wrist, hand, basically, which is all the same position.
Yes. I would agree that definitely the breast. I think that actually everyone should lay on that coil. Men, women, I think you should lay on there. I've volunteered, and it's very, very uncomfortable. And I was a volunteer. Yes.
I offered. They looked at me weirdly.
You offered? Okay.
This is fun for me.
I was gonna go down a path, but I'm not. But people don't need to be afraid of subtraction. They really don't. I mean, it's something that you take a risk. And this is from Dr. Bonnie Lee. Also, she's out of California. UCSF, I believe. She's been a great mentor as far as information for me. And she's the one that explained to me, I'm like, well, why do we not use SPARE? And she's like, because you make your time, it may go up slightly. So we just then do subtraction. We are not afraid to do subtraction. Then you also have to realize there are facilities that do breast imaging, and then there are dedicated facilities that just do breast imaging. So, their practices are going to vary based upon probably based upon their different types of situations. So, we just have to be very aware, and we need to take advantage of everything that we are given to optimize for these women. And then I'm going to talk about the time, because there's no way I could hold it. Hurts your sternum so badly. It's very uncomfortable. And I was on for a very long time because, again, they were just practicing protocols on me. So anyway, keeping that in mind, we have these things. We also have diffusion that we're able to do now. We definitely weren't doing that, in 91. We didn't start doing it in the brain until 97 at Emory. Yes, that's when we got the grading capability to where we're able to do it. And so, but, now we do it on breast. And for a while there was like, is there any significant, help in doing this? And it was basically decided, no. Is there a critical role? Not really. Then that was looking at pre-chemo versus post-chemo. Now there is a study out that actually says, hey, not a bad idea. But here's the thing with breast imaging. Timing is really important. People do not think about that. So 3 weeks post-chemotherapy, it was very, very little difference that you could see. But then if they actually scheduled the MR 12 weeks out, they were able to see, a big difference. Was the tumor shrinking? What was going on with it? And so here's a big thing. With breast imaging, you need to look at how you schedule it. It is different. So let's talk about, menstrual cycles. 7 to 10 days post. Now, understanding that if I walk in and they see something on mammography or the 3D mammo, then they do the ultrasound, then they say, this looks really bad. They're going to do the MR immediately. Right. Absolutely irrespective of these different things. But I don't hear people ask the question, when did you start your last menstrual period? They do it in pediatrics all the time. I mean, you don't have a choice as far as getting, a pregnancy test unless your parent physically signs a form. So why are we not trying to figure this out? Because you're going to get everything enhancing if you have it done while you're on your period. It's going to be sensitive to everything. It's going to be sensitive to everything, but it's not going to have a high specificity. Lights up. You're just going to be sensitive to all when you do the gadolinium. So that's very important.
We were kind of on the subject of obviously breast imaging, but I did want to kind of cover like protocols, like what it used to be and what it is now. So
absolutely. The standardized protocol, what's changed with that is it has gotten shorter because we are able to optimize the sequences a lot more. So I hear between 25 and 40 minutes of someone laying on a coil, which I think we've discussed already, is extremely uncomfortable. I don't care which vendor, who makes it. They are all uncomfortable after a long period of time. So the standard protocols typically are the ones that are followed. Those are the ones that really do cover everything that the ACR wants as far as ACR accreditation for breast imaging. Mm-hmm. Are they all necessary? Really think about it. A lot of times we do protocols, I call it like bloated protocols, where I am not even sure that they are actually looking at everything that I'm sending them.
Right.
And they know who they are if they're watching. But I think it's important to realize that we have to, with breast imaging especially, and the other areas that we talked about that, that people don't feel comfortable in, Superman position, things like that for MR enterography that's done prone, those types of things. We have to take that into consideration as far as only doing the sequences we have to. Again, the ACR accreditation, I mean, that's if you want to become ACR accredited in breast imaging. But, standard protocol, again, you're just going to have your pre-sequences, looking at the fluids structures, looking at, looking at the anatomy of your T1s. And so you're looking at that information, but the money scan is always going to be the contrast enhancement, the dynamic, and then doing the post-processing with the regions of interest to see how quickly did the contrast arrive. Where was the peak? What was the time to peak? What was the washout pattern? That shows the vascularity. I mean, that shows me how quick, and that's a bad sign. I mean, even me as a technologist, again, not as an MD, if I can draw a region of interest and I can look at these mappings and the cerebral, the blood volume, the negative integral that's underneath there. I can see that and know, wow, it got there fast. The washout pattern was really fast. Wow, extend my prayers in my own mind, and then the data goes on to the radiologist to take it from there. So those tend to last a little bit longer, but and some people, radiologists are going to want what they want. And so we'll do this. But we talked about earlier, subtraction. People move. So now something that's been happening literally for probably 15 years, she's been doing research. I said I would refer to her over and over again. I would like to have this woman's autograph. Honestly, I'm not even joking.
That's awesome.
She, heart, I really think that she has done so much as far as the evolution. She started doing something that we know of as an abbreviated MR breast protocol now. And so having that in place, I'm hoping in 5 years from now, as everything continues to move forward, that it's just called an MR breast protocol. I hope that we take that abbreviated portion off. Okay, because there's data out there, and I think that we do have a slide that I wanted to show everybody. And it was a study done out of Johns Hopkins. Let me see if I have it here in front of me. Yeah, it's a study from Johns Hopkins. And okay, the scan time was 3 minutes long. This is for an MRI of the breast.
What? 3 minutes?
3 minutes.
What is this, CT?
I know. You can't even do a brain in 3 minutes.
Nobody can. Yeah, you could, actually. We have a good friend that does them. He does a fast stroke protocol. And I don't know if there's someone that could whisper in my ear. It's less than 10. It's less than 10 minutes.
We're gonna
Rapid.
start. What I'm seeing, and I don't like it, is 15-minute time slots. I don't want that.
I know, right?
If it's
Totally
3
different
minutes-
perspective across the table. Anyway, this was done at Johns Hopkins. They did a localizer, a pre-T1 with FATSAT, and a post-contrast with FATSAT. You notice there's something that's missing here.
Right.
We don't have the dynamic contrast enhanced. So that's not here in this study. But the total scan time was 3 minutes. But if you actually go to the next slide, they did a comparison. They did a comparison of their full protocol. Full protocol. Now, this is from 2017. 2017. So the full protocol was 24 minutes. And the abbreviated, again, was 3. Okay, 3 minutes. These patients are on and off super fast.
Man.
So then look at cancer detection rate, 13.3 per 1,000. Oh, wow. Let's look at the 3 minute, 13.3 per 1,000. Identical numbers. Then go down to sensitivity, 81.8% versus 81.8%. Identical. 19 minutes difference. And then the only one that really had, that was, I don't know if you guys took statistics in college or not, but literally this is negligible, not even reportable really in my opinion, but it's the data. For specificity, it was 97.4% as compared to 97.2%.
Right.
So 0.2 difference. We're talking that much time, 24 minutes to 3 minutes. So I was doing this talk, and it's, definitely outdated information, probably 4 or 5 years ago. And I was talking about the abbreviated, I didn't have a lot in there on abbreviated protocols, but one of the technologists, I always get such great feedback from people in the audience. He said, we had a very forward thinking, MR breast, specific radiologist come in, and she was doing a lot with the abbreviated breast protocols. So we were talking earlier about, should I take someone from a 1.5 to a 3 Tesla? I said I would kind of pull that full circle as we kind of end this podcast. But what they did was they started doing patients. She was like, no, I'm reading them. I want the abbreviated. All right.
Nice.
So, and they did the dynamic contrast enhanced. Their patients were on the table 7 minutes.
Man,
So-
that's still amazing. Oh my
Right.
gosh.
They're typically always less than 10 minutes.
That's
No
awesome.
doubt.
Wow.
It takes longer to put the IV in.
Man.
I'm being
Depends
serious.
on who's starting it.
But then, the proof is in the pudding. Look at the numbers.
Yeah, if you get the same information.
I guess
Last time I checked, I think everyone knows Johns Hopkins, wouldn't you say?
I've heard of it.
Yeah. I think it's out there. I think it's pretty respected. And so, and this is just one that I pulled out because I knew that people would be able to relate. Oh, it's Johns Hopkins.
Right.
You always want to trust the facility, but there's a lot of other great data out there that is concurrent with this, especially coming from Christiana Kuhl. She thinks you're absolutely, I think that she believes that you're doing an injustice. So, couple things. 3 minute protocol. Where these abbreviated studies started from was people at intermediate risk where their insurance was not covering them to have an MRI. So, we have these different factors that are involved.
Right.
So then quick in and out, can we diagnose this? The patient pays cash. I've heard and I've asked every single group that I think I've ever done the talk to, runs between $350 to about $500. And that's actually from east to west. I didn't check just all the southern states, which are all in the south, but, and he's ignoring me.
I'm listening.
No, it ranges in that area. So it's something that's affordable. You go and you pay cash. So
Right.
then I would ask you a question. If your significant other, or if I went home and told my family, They say I have dense, breast tissue,
Mm-hmm.
but I don't qualify because I don't have any of the other factors. But there's a little area that, it's questionable, but they don't think that, the MR is not going to get approved. Do you not think that my family would scrape up every single dime from every single piggy bank, and my kids would not airlift me to get that MRI done for between $350 and $500?
Right. Yeah.
So this was really started from in the U.S. and pushed because we needed access to MRI when health insurance wouldn't pay for it.
Right.
So the radiologists were like, well, I just really need these sequences.
Right.
Let's go for it. And they're made a ton of money off of it. You could theoretically, I would say, do 3 in an hour, as long as someone else is starting your IVs. I mean, they're not long.
Yeah, you could really.
You could do a lot. So that's kind of where it came from. So then I'm talking, go back to the situation where this new doctor comes in. She's, from a large institution. They were doing so much with the abbreviated. She said, no, I'm going to be reading them. So you're going to do the abbreviated protocol. He said that patients that have been coming for a very long time for their follow-ups were like, we're done.
Right.
Wow. I'm not in pain. That didn't hurt. All the information, again, it's anecdotal. He wasn't, writing out, 70% of the people that I switched over, but he was just saying, you would not believe, Kristan. And it's so much more of a pleasure for us. And then you take it back to subtraction. If that fails in any way, then they're not on there as long. So they're a lot less likely to move. So we really have to look at moving in this direction. Again, I hope that word abbreviated is dropped.
Right.
Yeah, because that kind of lends, I guess, as MRI techs, we're just predisposed to the belief that if you reduce scan time, you're compromising some sort of technical factor,
Right.
which compromises the quality, right?
And right now, I feel like AI is making a big push for like lowering the scan
Well,
time
I think
for a lot
AI
of stuff,
plays a big part in
but
abbreviated.
still keeping all that information in there somehow.
Can I throw AI out there
I think that's
right
a great
now?
transition.
I love that. Yeah.
Yes.
That's a fantastic. I'm so glad you brought that up. I cannot find anything that is positive as far as the remarks for AI. As
Oh,
far
really?
as right, it's
Breast
just
imaging.
as far as MR breast imaging.
So
really,
what I looked up was faster reads and more and higher accuracy.
Oh, but that's on the post processing.
it's negligible. It's not anything that's. It really, you'll find one that says that there's
Just
no
the
merit.
opposite.
You'll just like you were researching, and yeah.
Okay.
Now, are we talking image reconstruction, or are we talking like how data are being processed and read through AI?
I think they're looking at sensitivity and specificity.
Oh, okay.
And so that's what I was reading up on today.
Right.
I'm not going to go for it or against it. I know it's evolving faster than I can eat.
So fast,
Yes,
right?
it is evolving very quickly.
scary.
So, we're having this discussion today, and literally in the next month, there could be a software or something that comes out that completely negates everything that I'm saying. I'm just saying right now, everything that I've researched over
Quick
the
disclosure, yeah.
past. Yeah. Well, absolutely. There's so much that you have to say. Actually, I think it's important to update things constantly, but do they always get truly updated? Because I'm always afraid that, Bill and I are giving out information that is outdated. It's some things are truly have a shelf life.
Well, when you
Right.
talk
Or
about
end of
dynamic
life.
imaging, I think modality of MRI itself is dynamic, so it's always changing. That's
Oh
the reason
my
why we
gosh.
kind of got in this whole podcast.
Yeah, that's true. And I love that you guys do this so much. But they say every time you think you understand MRI, it's like peeling an onion. You peel back a layer and you start to cry again because everything's changed so quickly.
You saw
know?
that?
I do that.
That's
Now,
real. I love that saying. That's
That-
great.
No, I mean,
It's
it's
so real.
a tech told me that, and I thought it's pretty true. Just when we think we've got things figured out, then they do
You pull back
something
another
that's like,
layer.
oh, I thought I understood sense, and then now they've changed that. They did
Right.
these. It's really become, and I think that it's important to understand all that. It's just something to think about, and I do think that in a lot of situations, people want to hold on to these sequences. When I did applications, I would go in and I would train them on the equipment, and there would be new sequences that were definitely better. Papers out there that said they were definitely better.
Right.
But the radiologist many times would say, well, you'll be back in 3 months or 2 months or whenever. Let's do both. Let's add the new one, but let's keep the other one just in case. And then I'll drop the other one. As soon as I'm comfortable with the new one, I go back 2-3 months
Transition
later,
period, yeah.
Still there.
still there.
Yep.
And they were sold a scanner that's going to be twice as fast in half the time, twice the signal in half the time, right? That's what they
Right.
all said when they were marketing 3T, correct?
Yep.
Yeah, you're going to get twice the signal in half the time. No,
Right.
right. Didn't
Twice the
happen. And
signal
so
half
the techs would be so frustrated. They're like, no, they haven't let that go yet. And that's a conversation I had to have with them. Same thing I think applies as a parallel here to the breast imaging with MR. It's hard to let go of all those sequences, whether you're really looking at, the fluid range or things like that. Can you not see it somewhere else?
Right. Well, if you got to give someone bad news too, I know you want to make sure that you are 100% correct on that bad news.
That is actually a very, very good point.
Right.
But also, you saw those numbers.
Right.
I mean, they're it's crazy.
Right.
Memorial Sloan Kettering is doing a lot of research on it as well, and their protocol. If you look at there's some information out there. They're doing so much as far as offering these, but they're also, I think, starting to adopt them as a regular protocol as well, while they're doing the different types of things. But if you were just to Google abbreviated MR, you can probably see abbreviated MR studies of the breast.
Actually, I did, and Dr. Is it?
Christiana Cool,
Yeah, she showed up.
probably one of the top things that showed up.
Pops up.
Yeah, I can't say enough nice about her. But the one study I showed you from Johns Hopkins, the National Institute of Health, they have a stance. All of the things that we see, they're really saying just positive things. American Society of Clinical Oncology, again NIH, Sloan Kettering. There's American Cancer Society. All these different things. There's nothing negative about this that I'm seeing.
Right.
There's no reason not to try this and to do this, especially if for nothing else to provide a service to people that are at intermediate risk.
Right.
And then hopefully over time, people will see, there is, I'm sure, I don't know anything about insurance. I don't. I have it.
Right.
My family all the time asks me, "You think I would know?" I have no
I
clue.
have no clue either.
I just pay the bill every month and hope that everything's covered that happens.
So I don't pay the
This
bill.
is me every time too. I'm like, man,
Or
I'm not gonna open it.
or
I'm
do
not
I
gonna
turn
open
this in or not?
it. Right.
Do I want to even turn this in as a claim? What's this worth to me?
Exactly.
I have a child that just turned 16 last Friday, so
Oh, nice.
And-
Big shout out. Nice.
yeah, big shout out to Big Paul. But he also, you boys are expensive to insure.
Yeah, well, he's about 300 pounds, so he's also expensive.
He's
to keep
360
fed. Yeah.
and 6'5" and a
Nice.
half.
Yeah, so he's also expensive.
You got
to
those
keep fed.
scholarships yet? Anybody looking at him?
You got to reach out.
Oh yeah.
No, a big one.
Nice.
Oh, congratulations. That's
Yeah,
awesome.
that's
D1
awesome.
5-star. It's his first.
What?
He's almost a sophomore.
That's awesome.
It is. It
Man.
is.
That's great.
It is. And obviously you can't do a reveal. You can't do anything. You
Right.
can't say
You
anything.
can't say nothing yet.
But I will say there's a lot of fingers crossed.
And what colors do you expect to wear in the near future?
Is it what colors?
I'm going through hippie stage this year. I'm just like I'm
You're
color.
tie-dye.
I'm into tie dye, which means if you read the undertones there, that
I
could be any
understand.
school,
I
right?
understand what you did there. Good for you.
I am protecting until you should see the reveals. I'm just being honest. The reveals they do for football stuff.
Oh, right.
I've heard
it's-
actually.
It is.
It's awesome, man.
And I think that's a good transition because as far as reveals go, see what I did here?
I like that.
I think we're all very visual, right?
Oh yeah.
So I'm wondering if you have any kind of case studies, examples of breast MRI we can kind of just see visually what it looks like.
I don't.
Let's pull it up. Dave, will you just Google like a breast MRI?
Hold on. I may right here in the presentation, which I can just pop on a disc and give.
Yeah, yeah.
I have the diffusion one that shows pre-chemo versus post, but I'm just telling you, people aren't doing a lot of it.
Is diffusion making a big move?
Okay, so you
With
see
breast?
that bilateral breast,
Oh, okay.
second row, second from the right. I think that's a good example. It's got a ROI right there.
One thing I noticed too is like I feel like you're not really seeing sagittals anymore in breast, right? It's bilateral, axials, and coronals. That was more of a Europe thing. Ah, making its way.
I have a slide that I want up there. I don't know how to.
Yeah, let us know. We'll pull it up.
Yeah, I think it's a good one, but I gotta find it first.
So, anyways, as far as MRI goes, the images that we look at, behind the scenes, this is what we're looking at right here. This right here is what's called an axial. We image typically in 3 planes: axial, sagittal. What's the other one, Reggie?
Coronal.
It's late.
Okay, so go ahead.
No. I'm just killing time. Go ahead.
Oh, you're doing a great job.
Thank you.
So I want to say this about injection.
Oh, yeah.
Injection and timing. I really do want people to actually put into the. I want people to put into the form. I want people to put into the form. What gauge needle was used, what injection speed was used. I think that standardization is really important to understand.
Right.
I think also weight-based dosing, 0.1 millimole per kilogram. I went to one large institution that said, we do have the radiologist. Kristan, we are doing a standardized protocol. Every single patient gets 10 ml of gadolinium. And I said, okay. So I was standing next to a very, very tiny petite girl. I said, I know what I weigh, but I'm almost 100% positive that she weighs like 90 pounds less than I do.
Right.
And so it's weight-based dosing. Yes, it is standardized. We give everyone 10 ml.
Right.
No. And I think that was part of like the GAD retention when I think everyone has, it's been around forever, in the bone, but once it went to the brain, they were like freaked out, even though there's been no repercussions. I think people have backed off on that as well. Weight-based dosing is weight-based dosing. So just do that. And then again, the delivery is really important. I would like to pull up the slide, and I'm not
just
sure.
for standardization, I'm curious about your opinion on the actual gadolinium vendor itself.
And
without naming names.
Without naming names.
Do you think that there's an importance about having the same sort of gadolinium? Like Gadavis, multi-hand.
For every time they do their breast MRI?
I think it's okay. I'll speak to what you have to say. I think, not that I'm not listening. I'll speak to what you're saying is that if you do change contrast agents for breast imaging, I would maintain that same contrast. For breast imaging specifically, there are facilities that will use another vendor or another
Just for
manufacturer, pharmaceutical manufacturer for everything else, but they will use only one for breast.
Okay.
And that can have to do with the facility. Are they looking at stability because they're going to have multiple? It's like it's like a patient with Crohn's. They're going to have a gazillion of these MRIs, or are they looking at relaxivity? That's going to be with a higher relaxivity. Okay, does that give me flexibility? And I'm again not talking as an MD, but okay, well, higher relaxivity, can I give them a lower amount and still have the same as far as enhancement, or can I give them the standard dose, which is what we're supposed to do, and actually see more and have better differentiation as far as the specificity and the sensitivity? Will I see additional lesions, which there are papers where there are things like that happen. So I do think the contrast does play a big part, but also I think there's a lot of different things that come together as far as making that decision for the facility and for the patient.
Yeah.
Did I you think I handled it? Is that okay?
Absolutely. That was perfect.
Oh, yeah.
Yeah. Am I getting a thumbs up from anyone else in the room?
For those of you watching at home, we got 2 thumbs up behind the camera.
Yeah.
Yes, absolutely. So, we covered that. And then I really wanted to show maybe this time intensity curve. And then I don't know where you want to put that in, but I will tell you, for those, I know that we're still recording. If you are at intermediate risk, if you have any concerns, you can definitely Google abbreviated MRI of the breast near me. I mean, literally, and you can find places that are doing it. And I'm telling you, and then a lot of times I've been on people's websites and it says, click here to schedule. And you just put your information and do it right there online. So there's no reason not to.
Well, I'm surprised I haven't seen a dedicated breast scanner.
Oh,
Are there some out there?
There used to be one made by, I believe it was called Aurora.
Oh.
And it was pink and, met all of those things. But there are definitely special tables that attach. I think one's called MammoTrack. I'm not sure if that one is still being sold for certain reasons. But definitely there are dedicated types of tables that you can purchase for your system. And so, yeah, definitely are out there, but there is the company Aurora is no longer, and I'm not sure if they were purchased by somebody else and they used part of their technology, but they're not a company themselves anymore. I know there's a lot of dedicated breast centers, but they don't have the dedicated MR systems that are made with pink and have roses on them. So I mean, just going there. So as far as the plane that you use, that's going to be axial versus sagittal. That's really comes down to a physician's preference. I mean, that's what I find everywhere I go. One place is going to say, it's just like you were looking up articles a second ago. One said good, one said bad. It's going to be what how they were trained typically.
Yeah, either way, it's going to be a profile image, right? Versus a coronal, which is like a short axis. Either way, it's going to be a long axis.
Yeah, either way, you're going to see. Yeah, it's going to be the way that it has to be done. And also, you also have a limitation. It used to be that we had to do one breast at a time. Think about it, because when we do it sagittally, and then think about this, they had to come back a couple days later, have the other one done, and get another injection of contrast.
Right.
Because so we have come a long way. And so then there was this big thing. Bill and I actually went to a great facility in Tennessee, and they let us look at their 3D mammography, which I found to be extremely impressive. But a study I was reading about just recently said that MR is still far superior to that even. I really thought, oh, wow. I mean, obviously we have the non-ionizing radiation, so we're the go-to. And Raj, you were saying earlier, more and more is moving to MR.
Yeah.
I really feel like where I work, the ER, it's CT, there's no patients. I mean, unless, I always say this is the truth because it did actually happen. There was a child, unfortunately, that came in with a very sharp, large object that was highly ferrous in his chest. So he had to have, but he went to CT. But I always tell Bill that the MR department is become, it's trauma MR. Anything that, because we're in a pediatric atmosphere. We're under an absolute microscope, and I would assume that most people are as far as the ionizing radiation. So I feel like a lot of trauma, so on and so forth, is moving toward MRI. And I think we saw that's really starting in pediatrics to begin with. I do. So you're correct. I don't know what else we can do in MR.
I worked at a facility. It was a level 1 trauma center, and we did a lot of C-spine trauma. So you're looking at that transverse ligament on the top of the odontoid. So you do a nice T2 axial through that. So yeah, I experienced that personally.
Absolutely. And all of those are done at the pediatric facility. They literally, we have the foam next to their head. You're very careful, and then they're moved over, and we actually do that for injuries for the spine when they're on the backboards. And so a special protocol for that. So that just reiterates your point. Things are moving over, things that we never would have thought, would have been done because, why not just do a CT? I think that things are moving more and more toward MRI, which I think is a good thing for me. And it's a good thing for you.
For us, for
a good thing for the patient too.
And it's a great thing, I was going to say, and it's a great thing for the patient because if you really think about soft tissue, I mean, who would want to? You look at cortical bone with CT,
neuroimaging.
Yeah, I mean, but I think about it for breast. That's really not an option in breast imaging, right? I mean, yeah, I guess it's an option, but is it a good option? No. MR has really taken mammo, 3D mammo, which came out after obviously ultrasound, and just taken it to a whole new level. And so I think one of you made a point. Why even do all the other stuff? I can't answer that. That's probably part of the process. I know with my husband's recent surgeries, he had to have an x-ray. We absolutely knew it was an ACL tear. I mean, there's no doubt based upon his symptoms, and then he had a rotator cuff tear. There's no doubt he can't lift his arm without screaming this far, but you got to have an x-ray first.
Sometimes that is how the insurance works. It's like you're not going to approve stuff until you get,
I think that's
it's counterproductive though. I mean,
it is counterproductive, and I disagree with it, and I'm not sure if that's just certain, companies, because it actually ends up costing them more.
I don't know. It just shows a lack of understanding to me.
I'm not going to go down the insurance avenue with you. It's crazy how things work.
That could be a whole nother podcast. Right?
And then, I can't even go into dental because I don't even know I have it. Okay. So anyway, that being said, I think that it's important for us to be very progressive. The equipment's met us. Okay. They've met us and they're going to keep going. So why would we as individuals not try to make them just more comfortable for a 25 to 40-minute exam? Why don't we have a discussion? I always love discussions with the radiologist.
Right.
And they actually enjoy it more than people would think. They actually say, when we all meet together and Bill and I do conferences, they actually, they really talk. And they're like, oh, I don't need that sequence. I don't know why. I thought you just had to do it. I mean, these things happen. So why not have this discussion? I always try to go armed. That's what I say, armed as far as the information that I have, and say,
sure,
hey,
I know how you Southerners are.
Hold on.
You are in Arizona, though,
I really don't know. I don't know what it's like here, other than it's
just know. Just every car.
Really?
I mean, statistically, not every car.
Somebody's holding something.
A majority.
1 in 8.
Really?
More than 1 in 8. This is higher than breast imaging or breast cancer statistics.
Really, like 1 in 6, because that's you males.
I would say one in 2. Right? Who's packing in their car here in Arizona?
At
least 50%. Yeah.
I suddenly became more scared in this room.
Yeah.
Well, I mean, I have underneath this. Don't look underneath the table. That's all I'm going to say.
Not sure I would want to anyway.
I just have mine on that.
Such a nerd.
I love you being a nerd. No, I just think that, the technology has really come to us, and I want us to also and keep in line with the patient and just taking care of them first. Yes, I wish we could jump ahead in line and skip some of the other modalities. But you know what? They may be all compared to each other.
Right.
Again, none of us sit here as a radiologist, and the person that's ultimately, you're saying, it's a CYA type of situation. Do we need all of this in conjunction? Right. So that part I won't answer to, but yeah, it would be great. But I'm pretty sure that, I'm not trying to offend anyone that does ionizing radiation, because I'm sure that mammography is a critical component of it. But MR is now considered superior, and any article pretty much you would find is going to say it is going to be superior.
Right.
So the
last
last
thing
thing
anymore, right?
Right, exactly. The last thing I would just say is just really keep the patient in mind, the patient comfort. If you are able to find enough data out there to support doing these abbreviated protocols, again, look up Christiana Cool, Christiane. As the first name, and Cool is Kuhl.
That's a cool last name.
She is a cool bad.
She's born in Germany, from the information I looked up, and you lived in Germany, right?
Yeah.
Were you born in Germany?
Man, I was born in Germany.
I thought you were from Georgia.
But I am from Georgia. I'm a very fluid,
multicultural.
Oh, yeah.
He's a melting pot of.
They call me Megatron.
Do they? Well, that's because of your digital stuff, right?
Yeah, a little bit of that too.
Yeah.
You know what I'm saying?
So you're kind of a geek.
There's such a great joke I want to say right now. Not PC.
I know. I will tell you this. I have found it's very difficult for me to say PC about anything anymore.
Oh yeah.
I'm afraid of I can't say someone's overweight. I have to say they're circumferentially enhanced.
Well, this is the joke I make with my kids. So there's like a arcade video game, bowling alley, movie theater called all in one place here in Arizona called Fat Cats. And so my kids will be like, Dad, can we go to Fat Cats? And I said, little guy, we don't use that. We say unhealthy cats in this family.
Morbidly obese cats. Yeah.
But I think, Kristan, we covered it for the most part, right? Do you think didn't cover anything?
I think we've covered everything. I just, I really hope that we continue to move forward from our side of things. A lot of times we have trepidation as far as that type of change.
Right.
And so, but then I want to make sure that I thank Zone 3 Podcast D3. I think everyone should be, there's so much value to it. And I appreciate you having me. Obviously, Aegis, I appreciate them reaching out and being a sponsor
But I will come to you guys in Phoenix anytime. Reggie, I love you. Robert, I love you. I think
Thank
you're
you.
both,
Dude,
I'm going to still, don't forget the restraining order, but
I'll take away that mental hug that I'm giving you right now. Then don't let go. I have it.
no, but thank you so much for having me here today.
Yeah.
Thank you.